the instruction and I'm ready for the structured discussion. Okay, Shabnam, you are a specialist trainee on the delivery suite and you have 8 patients. Prioritize them. These are the following staff which are available with you. Proceed accordingly. Okay, thank you. I have taken the charge of the labor ward at 8:30 a.m. along with my colleagues, my team. I will assign the task to my colleagues according to their competency. Keeping in view patient safety will be my utmost priority. I can change the task in between the priorities, in between according to the situations. When I took over, I will quickly review the notes of my patients, see their history, comorbidities, blood group, any Jehovah's Witness. Will make sure advance directive. If not signed, that it will be signed and attached in the documents. Medication, allergies, previous surgeries, BMI, and risk of VTE will be noted down. First of all, I will go to room number 4. She is DA para 1 plus 0, 34 plus weeks membrane intact with the pervaginal loss, most urgent case. I will attend by myself as she is bleeding, so want to know about the amount of the bleeding, gestational age of the patient, and any pain. I will alert my team, arrange the investigation, that is complete blood count, arrange the blood, ultrasound to rule out the placenta previa and abruption as well. We'll do the CTG and see if not previa and patient is in labor. We'll do ARM and check the color of the liquor as well. Steroids cover will be given, vitals will be maintained, inform the neonatologist as well. Availability will be confirmed. Now I will go to room by room. So this room will be top urgent and will be managed by myself. Now I'll go room by room. Room number 1, patient JJM para 0 plus 2, 33 plus 2 weeks, membrane intact, dichorionic, diamniotic, twin contracting, both CAF. So we'll ask briefly about the type of twins, presentations, previous obstetric history, any pain, since how long, if pervaginal examination done, what was the finding. We'll rule out UTI as well. CTG will be done for my patient. NICU availability will be confirmed as she's 33 plus 2 weeks. A neonatologist involvement will be done. Steroids cover will be given. Monitoring of this patient will be done. Continuous electronic fetal heart rate monitoring, examination, and maintain partogram. Right now, this is semi-urgent case. Midwife can monitor the case. At time of delivery, I will make sure to be present because complication with the twins is high. Now I'll go to room number 2. The patient SK para 2 plus 0, term plus 6, membrane intact in spontaneous labor. I will quickly take the history, the recent examinations, abdominal and vaginal examination will be asked and confirmed, and maintain the partogram of the patient's routine case. So this will be monitored by midwife. Now room number 3. She's PV para 0 plus 2, 36 plus 2 weeks, emergency C-section due to the fulminating preeclampsia. As she is delivered patient, she's a postpartum case. Want to know about the recent blood pressures, the pulse, the urine output, and the general condition of the patient, what medication she is taking, what are the observations. The news chart record will be checked, intake output chart will be seen. If needed, then we'll repeat the investigation. So right now it is a semi-urgent case. If need any medications, any treatment for the raised blood pressure, that will be prescribed if needed. It is a semi-urgent case, so anesthesia registrar and midwife will monitor the case. Now room number 5. Patient is OK, 0 plus 3, 39 plus 2 weeks, meconium stain liquor. What is the current abdominal and vaginal examination? Now CTG if normal, then continue monitoring, otherwise fetal blood sampling and expedite the delivery according to the findings. If need C-section, then anesthesia involvement and neonatologist at time of delivery. Anesthetist to be informed. It is a semi-urgent case. ST5 will manage once free with the most urgent case, otherwise inform the consultant as well. If significant meconium, then continuous electronic fetal monitoring and delivery will be expedited. Room number 6, JR, 0 plus 0, 42 plus 1 weeks with clear liquor. So ask about the current current condition, current condition of the patient, the fetal heart rate, abdominal, vaginal examination, station, position. As patient is fully from 5:30 a.m., it is almost 3 a.m., 3 hours, primary 3 hours with epidural. So according to the station, expedite the delivery in labor room with the verbal consent or in the operation theater with the written consent. Patient will be counseled semi-urgent, assign the task. So I will assign the task to the midwife in charge. +1 will if the station is higher, then patient will be shifted to the operation theater. The written consent will be taken accordingly. Now, room number 7. So this is semi-urgent case, midwife in charge will monitor the case. Room number 7, patient FN, para 2+1, previous to C-section, 38 plus 3 weeks with intact membrane with pain. So I will ask about the vitals of the patient, the abdominal examination, the contraction, scar tenderness, look for sign of impending ruptures. The pulse is important in this case. Review the notes. Plan of delivery. Location of the placenta will be checked. Involve the consultant. If patient want trial of labor, then risk will be explained. Consent will be taken. OT staff will be informed. Anesthetist will be informed. IV line will be saved, blood group and arrange will be done. So right now it is a semi-urgent case. ST5 will monitor. ST5 will look after the patient, but midwife can monitor this patient right now. A consultant will be informed as well. If the patient don't want a trial, then patient will be shifted for the operation theater for the cesarean section. Once that will be done by the ST5. If she is not available, then the consultant will be informed for the patients. Room number 8, patient VC para 5+0, 40+4 weeks, membrane intact in labor. I will review the notes, observation, abdominal vaginal examination, fetal heart rate, previous deliveries. As she is a grand multipara, will be vigilant for the postpartum hemorrhage. So active management of the 3rd stage of the labor will be done for the patients. IV line will be saved, blood will be cross-matched because risk of postpartum hemorrhage. So this is partogram will be maintained. It is a routine case right now. Midwife will monitor, but at the time of the delivery, if the midwife need, then I will be available with along with by myself as well. In case of postpartum hemorrhage, the team will be alerted for this case patient. Thank you for your time.